So, Laura, did that answer your question?
I actually, have several things that I'm going to take back out of that. I think the idea of what are the basic principles, applying that and combining it with Will's comments of looking at the particular, the class levels and start looking at what problem are we really trying to solve here. I was thinking in what I had in mind was the notion of avoidable admissions to the ED or to the hospital. And I was thinking about then approaching this plethora of innovations from a class and also from, what basic problem are we trying to solve? What's our hypothesis about the returns? That there are many, and there are some really good ones, and there are some data to go along with it. So I found it very helpful.
Yeah, Kate, I saw your hand up.
Well, first of all, thank you. I think these were very interesting and provocative presentations. I'd ask you each maybe to comment. I'm thinking about how there certainly is potential for consumer engagement to help improve health. And I'm wondering, though, given people are so inundated with information, what thoughts you each might have on how best to, segment the population and target them in terms of, getting people engaged and how you decide who, how to prioritize and some of those kinds of things. I know that's that's another hour. So if you could each comment on, segmentation and how to best reach people with these types of messages to engage them.
Well, I'm always hesitant to start this out without context because we know that so much of health IT is asking doctors to do additional things. But we have found increasingly in our conversations with consumers and consumer advocates and groups and our research that the most trusted messengers for health IT tools that they find effective are providers. And we've been working with ONC on a consumer education campaign to disseminate information not only about health IT writ large, but specific types of health IT, the benefits and privacy and security specifically. And we're hoping to extend that campaign and conversation and series of discussions to providers as well, because if we can have it be the providers that, based on their knowledge of the particular patient, the segmentation can occur there because they know who the patient is and they know what that particular patient's needs, and they can help explain and contextualize the particular kind of health IT. We found that seems to be an idea that resonates most with patients and actually providers as well.
I think your question is one of categorization. Okay, how large or how small you want to, I guess, define the sample population, and I think that the principle that I would embrace is that as those who innovate and those who seek to embrace innovations, you're in a situation where you want to rapidly prototype. You want to have as many iterations as feasible given the resources that you have. So choose a population that really fits your need, but allows you to conduct as many experiments, if you will, okay, as possible, okay, and that would really increase the size of your final data.
President or David Blumenthal or someone like that haven't helped me. I would I would focus very hard on those younger than 10 years old and teach them to be responsible citizens in the health world. If I had to do it over again, I'd be a pediatrician, and I'd be working probably with pre-kindergarten and kindergarten kids to teach them what it is or to try and begin to teach them what it is to act responsibly with respect to their bodies and their minds. And they will then push us. I mean, if you do have grandchildren, I have a lot of them, who are so comfortable with these emerging technologies and will blow all of us in this room away effortlessly. The question is, how do they use them? Not whether they'll be able to or what data they'll do, is will they use them wisely and well, or will they use them to blow up the world? So my suggestion to all of us is that we retool and get into the pre-kindergarten levels and begin producing a really responsible citizenry, which can apply to rich and poor alike. It doesn't matter. It can apply across this country. They all have the same gifts. We just make sure that we ruin them as time goes on.
Michael.
Yeah, thank you for the presentation. Question, you didn't show the numbers up there, but I'm interested with the open notes, when patients did get their visit notes, was there much back and forth with the provider and the patient? Did that have more dialogue with the provider and patient after that?
Well, that's exactly what we're studying. The honest answer is I don't know yet. I can tell you this, that in Norway, they began to do this in 1970, and everyone yelled and screamed, and then the yelling and screaming disappeared, and everyone does it. The MD Anderson Hospital, which, as you no doubt know, is probably the biggest cancer hospital in this country. It gets 30,000 new cancer patients a year, 10,000 from Houston, 10,000 from Texas, and 10,000 from the rest of the world, many from DC, I suspect. About 18 months ago, overnight, top down, no participatory democracy, just turned on the machine for all doctors, not just primary care doctors. We're just studying primary care doctors at this point. And they're perfectly happy with it. They're about to study it. Unfortunately, they didn't study it from the start. Thank God they didn't go to the Johnson Foundation before we did and say we want a grant. But
They would have been transparent about that.
Pardon? That's right. But it's not ended their world. And in fact, it's actually quite interesting. Their goals in this have been bifold. In fact, I think they would agree that their primary goal was for referring doctors from all over the place to be able to follow the patients they referred in their course through these awful illnesses through their hospital. And maybe a little bit as an afterthought, they said, why shouldn't patients and families be able to do it also? One of the fascinating questions, by the way, is what is the impact on the caregiver for those who are ill? You know, caregivers themselves have an enormous burden of illness. Many of us in this room have probably had to care for people who are sick. What will the impact of such back and forth, such transparency have? We're studying that. That's the fun of this game, and I can't answer your question yet. I haven't been murdered at my hospital. Okay. I will tell you, though, that when I was on NPR, there's a certain amount of competition in Boston, as you may know, among hospitals. Tom Lee, who has a very good mouth and is very smart and is at the Partners, an institution near to us, was quoted by Dick Knox as saying, "It's a terrific idea. I think everyone should do it. I'm so glad that Beth Israel's doing it." So.
Okay. Yeah, David.
So first, I'll say I think the Open Notes project is one of the most interesting and important ones in a decade, and I'm so glad you're doing it instead of us. When we first heard about it, our doctors, we talked about it within our group, and everyone said, wow, that's really brave. One of the most interesting things to me is whether the doctor and the patient begin to think of themselves more as a team. And do the physicians actually start writing for the patients and use less jargon and less abbreviations to intentionally make this more accessible? And on the patient side, you talked about are patients more likely to follow these recommendations. I can't remember if you used the term adherence. But to me, one of the most interesting things is, are patients finally honest about their non-adherence? And do they say, you know, now that you're being open and honest with me, you've got this statin therapy on the medicine list, and I haven't taken that in a year. And we know that that happens at least half the time for treatment for sleep apnea. It happens probably more like 80% of the time. And even though we ask questions about this, we know from actual fill data or now from the sleep apnea studies, we're getting the data back on patients' actual use. And it's still very hard for patients to be honest about these things. So are you looking at that, and how do you think that's going to change?
Sorry. Will doctors change notes? I think the answer is yes. I mean, I've changed my notes. I'm not part of the study for obvious reasons, but I am part of the study for obvious reasons. I give examples that everyone laughs at. SOB. David knows that SOB to him and me means shortness of breath. But if I describe some of you as an SOB, you may not like it. And there are other there are other examples of it. The ubiquitous use of just abbreviations, which I can't follow, much less the patients. Dyspnea is the technical word for shortness of breath. Why not write short of breath? So I find myself writing short of breath. We don't have enough money to study it really carefully. Those studies are fraught with hazard, as you and I know, and they're sometimes not worth the money, but we're going to certainly ask the doctors afterwards, did you find yourself writing notes differently? Now let me give you an example that I find very exciting about this. Doctors write notes, right? And then they write you letters after you've seen us saying this is what we found and this is what we recommend. Patients can only read the notes once we've signed them. And I'll tell you a deep, dark secret that doctors don't always sign notes the same day they write them. In fact, it can be months later in some circumstances, which isn't good. But I dictate a note. In my privileged situation, I dictate it into a machine. It's translated by a voice technology. It goes flying over to India. Someone in India tries to fix my grammar. It comes back to me. It's on my computer the next day. And then I can look at it, edit it further, and sign it. And then when I electronically sign it, it's an official note. Well, if I don't do it the next day, or even if I do it the next day, the laboratory data from that visit are back, right? I asked the patient to get this blood drawn or that blood drawn or this x-ray taken after he or she left me. We agreed on that. So my note's different. It begins, this is an open note and incorporates the findings of our last visit. And then I draw on that to make suggestions to the patient and then may or may not hear from the patient about that. Well, that saves me another letter, doesn't it? I don't have to write that separate letter. So while someone here before presumed it would be more work for the doctor, one of the really important things we're studying is it indeed more work? For example, let me give you a hypothesis, that for every patient who will bug me more as a result of this and bring the beleaguered primary care doctor's life to a grinding halt, which it's teetering on anyway, there may be another patient who will bug me less. So that the net impact in terms of my work life or just hours spent may be negligible or zero. That's the kind of thing we're looking at. And I would encourage you not to be sure of the outcome before we find out what it is. We're not sure what we'll find, but you can make many hypotheses about that. In terms of the patient honesty and openness, that's an hour's discussion. I usually begin with most patients saying, I know you're not taking all your medicines. I've never been able to do it. Why should you? Fess up. And then I'll get a fairly accurate answer usually, but that kind of, it's how we frame things, isn't it? How we talk about it. We used to talk about compliance. You'll notice David said adherence, so we're down from the top down compliance, which to me meant a stiff lung in my old days, actually. How stiff the lung is a term of pulmonary compliance. To now we're doing adherence, because that presumes that we're in a more level playing field. People now don't like adherence so much, so there's a great debate among the semantics professors about what we should use. But I don't know what the answer will be. I don't think it will make them less forthcoming. My own real fantasy, if you want to know, is that we will jointly generate notes, that patients using some of Will's technologies will come to the table with a lot of the history already written. Warner Slack at our place has been having patients talk to computers for 40 years, 50 years, and is now just finishing up a very exciting program in which part of the history will be generated by the patient. I'll generate a note, the patient will edit it. My fantasy actually is that we will co-sign it. And that will in effect become a contract between me and my patient.